Hello everybody, my name is Jenny. Welcome back to my YouTube channel. This is the third video of our practice considerations for anesthesia professionals for methamphetamine substance use disorder patients. Our previous video talked about a brief history of the pharmacology and pharmacokinetics of methamphetamines. If you haven't gotten a chance to watch that video, I do recommend that you go back and view that. However, we will be doing a recap of some of the pharm and our guidelines and precautions. First thing you want to do, I'm recommending based on what the literature says, is not to restrain your patient. And I should say not to physically restrain your patient. We've seen this happen before, right? Somebody has been suspected of using substances, they get tased, next thing you know they're dead. But why? Well, they think that they have these isovolumetric muscle contractions, which is putting strain on the heart. And you can get the same thing for methamphetamine substance use disorder patients who are coming into the ER/the OR. So you're not going to want to physically restrain those patients. Please do not physically restrain your patient. Instead, chemically restrain your patient. How they recommend doing that with benzodiazepines every 8 to 10 minutes. What is the most common benzodiazepine we have in the OR? Versed. So what you're going to want to do, give 2 milligrams every 8 to 10 minutes until desired effect. And by desired effect, I mean that your patient is calm enough to be sedated for the anesthesia procedure. Now, they are recommending that you give your patient up to 20 milligrams of Versed. Yes, I did say 20 milligrams of Versed. Yes, that is a lot of Versed. But your patient might need it, and that makes sense, right? When they use methamphetamines, you have a catecholamine dump. Dopamine, norepinephrine, serotonin, they're ramped up. They might need that 20 milligrams of Versed. They might even need a second medication, Haldol. And we'll talk about this in one of our later videos, but Haldol might be a medication that you want to go to first for a certain subset of population. What about hypertension? Most of your hypertension is going to be solved using your Versed and your benzodiazepine. If it's not, you're going to want to go to alpha antagonists like phentolamine, nipride, nitroglycerin, alpha 2 agonists like Dex. Dex is great because it also has the sedating properties as well. Calcium channel blockers, but please be aware that sometimes you have that vasodilation from the calcium channel blocker, but you can also cause more tachycardia. So that might not be your first line that you want to use. And do not use any beta blockers. I'm going to put a little addendum note here. There is an author, Dr. John Richards, out of UC Davis, and he has several papers that have been published saying that he has been using beta blockers for treatment of hypertension and tachycardia in their methamphetamine substance use disorder patients in the ER. I did reach out to Dr. Richards, but he has not gotten back to me. So I'm going to have to go with what the majority of the literature says, and the majority of the literature says do not use any beta blockers. However, Dr. Richards, if you want to go ahead and email me, I would love to talk about this. So if you guys see this in a future video, we might be updating our recommendations for what to use for hypertension. In the meantime, no beta blockers. Tachycardia, same thing. This is going to be solved usually by benzodiazepines or antipsychotics. Calcium channels, please remember our note about maybe it causes tachycardia. Probably not going to be your first line there. Truly, your first line is going to be benzodiazepines. And don't use any beta blockers. Hypertension. On the flip side, once you put your patient to sleep, you might have profound and persistent hypotension, which you can only treat with direct-acting vasopressors. This makes sense, right? You're not going to use ephedrine because ephedrine is just going to dump our endogenous supply of catecholamines. We've already dumped that. We don't have any more. So you're going to want to use norepinephrine, epinephrine, dopamine, phenylephrine. Usually we have phenylephrine in our drawers. Sometimes some of us have dopamine, but I am recommending that you get the epinephrine drip or norepinephrine drip going if you don't want to keep just pushing and pushing and pushing phenylephrine and you feel like nothing is happening. That's what happens a lot for our methamphetamine substance use disorder patients. Neuraxial guidance. I found this particularly interesting. It is not contraindicated. So if you have somebody who comes in, a lot of providers are saying that you can't give spinal or epidural. That's not true. You can. It's just that on the flip side of that, you're going to see profound hypotension, which same thing, you're going to be pushing pressors and it's just not going to do anything. If you think that neuraxial anesthesia is the best selection for this patient, you can still give it. Just also keep in mind that you might be supporting their blood pressure. What about a patient on amphetamines? What do I mean a patient on amphetamines? So some people might be taking amphetamines for treatment of ADHD, right? There is literature saying that there's no need to stop this medication. They don't have an increased blood pressure lability, right? They don't have a lot of hypertension that we've seen with specifically our methamphetamine substance use disorder patients. So there's no need to say you need to stop it for 5 to 7 days or whatever. Just, stop it at your standard NPO guidelines. What about the acutely intoxicated? There's a research article that came out looking at ICU patients who were intubated, who were cocaine users or methamphetamine users, and it indicated that there was not the increased demand for sedation medication. So these intubated cocaine users, methamphetamine users, did not need more propofol, more fentanyl, etc. I particularly find this article very shocking. You would think that when you have the huge catecholamine dump that they're going to be ramped up, that they will need more medication. But per these articles, it's not what it's saying. So the only thing that I'm going to bring to your attention from this slide is that keep in mind, especially if you've given your patient a lot of benzodiazepines, you might not need to go to that 1.3 MAC, 1.4 MAC to keep your patient down, and that perhaps if you're over-sedating with anesthetics, that you're actually making your hypotension worse. Just a little nugget of information. Hyperthermia is usually used to muscle activity. This is not anything that has to do in your brain. So you can give Tylenol, but Tylenol isn't going to really be effective. The thing that you're going to want to do, same thing as always, give benzodiazepines. And muscle relaxants. Succinylcholine is a relative contraindication because of rhabdo. They're not entirely sure what causes the increased likelihood of rhabdo from methamphetamine substance use disorder patients, but they are finding there is an increase. There's a few kind of schools of thought of this. One is that there might be some skeletal muscle involvement. The second is that somebody who's using methamphetamines isn't taking oral intake like they should. The third is vasoconstriction. So if you don't have Sugamidex and you're really not comfortable using rocuronium or vicuronium, or if you wanted to dose this atracurium, etc., appropriately, and you really thought, I want to use succinylcholine here, just please keep in mind that it might have an increased risk for rhabdo. And if the patient does go into rhabdo, same kind of treatment like any other treatment, fluid boluses, maintain ventilation, etc. And that is our basic overview of guidelines based on what the most current literature says. Just keep calm, carry on, and in our next video series, we'll talk about parturients and what you can do for your pregnant patients. Thanks. Bye.